Hi, and welcome to today's tutorial on wound care management. There are three phases in wound healing. The first phase is inflammatory, which is followed by proliferative, which is followed by wound maturation. In the inflammatory phase, polymorphonuclear leukocytes, or PMNs, which would include neutrophils, eosinophils, and basophils, so our granular immune cells, will destroy bacteria. Later, macrophages will debride the wound, so they'll eat away at the necrotic tissue and release growth factors. Later, proteolytic enzymes will degrade the dead tissue. The wound at this point appears red, swollen, and it will grow a soft covering. In the proliferative phase, collagen is produced by fibroblasts. The wound scar appears to be raised, red, and hard. In the maturation phase, there is flattening of the scar by remodeling and removing existing collagen and replacing it with new collagen. To reach the maturation phase, wounds take about 9 to 12 months. There are 4 kinds of wound management. In primary intention, the wound is closed by sutures, staples, adhesives, flaps, or transfers. There is a rapid return in function. Cosmetic results are good, but there is a risk of infection. Where wounds are clearly infected, where there's bacteria count greater than 10 to the 5 or obvious pus, the wound is left open and a dressing is applied where gauze is moistened with saline and packed the wound, covered with a dry dressing. The gauze will dry out, and when it is removed and changed, the wound will get some debridement. Granulation forms in the base of the wound. Granulation tissue is new connective tissue with tiny blood vessels. Wound contraction is gradual. It will result in a scar that is not always cosmetically appealing. Low chance of infection, so it's reserved for highly contaminated wounds, like an abscess. In delayed primary closure, it's a mix between primary intention and secondary intention. The wound is managed as secondary intention for 5 days, and then when the wound is clean with some granulation tissue, the wound edges are approximated with sutures, staples, etc. There is less risk of infection because the tissue has become vascularized, and all that vascularized tissue is bringing immune cells with it. In skin grafting, there's a large surface area, full thickness wound which cannot be closed primarily. It may be perforated to prevent blood pooling, which would prevent the take. For the first 48 hours, the wound will get nutrients from the recipient bed. In terms of what's influential to wound healing, a clean and debrided wound needs to be, it's important to clean and debride the wound. Contaminated wounds should be irrigated and debrided. Bleeding needs to be controlled to prevent hematoma formation. And in terms of nutrition, the key ones are zinc and vitamin C. Also vitamins A, D, and E. Vitamin C is needed for collagen synthesis. Zinc is needed in fibroblast and immune function. Magnesium is needed for protein synthesis, and then the fat-soluble vitamins, with the exception of vitamin K, are used for fibroblast function. So all these things are important in the phase for proliferative. In terms of diabetic patients, hyperglycemia will inhibit fibroblast for action and endothelialization. Diabetic patients are also more at risk for pressure ulcers, which are a form of wound. They also have decreased wound healing just in general. In terms of medications, steroids inhibit inflammation, which is the first phase of wound healing. They also decrease vitamin A availability, and vitamin A we know is important in fibroblast formation and activity. Chronic illnesses predispose to infection and malnutrition, and smoking decreases oxygen availability to the wound. In terms of anesthetic choice for wound closure, there are 2 families of anesthetics, amides and esters. Amides include xylocaine, bupivacaine, mepivacaine, and prilocaine. These are short duration to onset, and they have a variable duration of action. Esters you need to be more careful of because when they're broken down, they produce p-aminobenzoic acid, or PABA. These have a sensitivity in some people, so they would include procaine, chloroprocaine, tetracaine, and cocaine. The duration tends to be a little longer, the onset to action similar to that of the amides. All of these are topical anesthetics. How do anesthetics work? They decrease cell permeability to sodium, which decreases the rate of depolarization and firing. These are often administered with a vasoconstrictor, such as epinephrine. The reason that they're given with a vasoconstrictor is to increase the proportion of the area which is closed off by the wound, and to help with wound healing. It's important not to give the vasoconstrictor in tissues that are supplied by end arteries, because vasoconstriction would lead to decreased oxygen availability and necrosis of those areas. So those areas could be nose, fingers, toes, penis, and ear. In terms of classification of wounds, a clean wound is a new wound which has little contamination and needs debridement and suturing. An avulsion is when skin is sheared, creating a flap or a loss of skin. This needs irrigation, debridement, sutures, and wound closure with a pressure dressing to prevent fluid collection. An abrasion is a superficial loss of epithelium. It needs irrigation to prevent it from drying out. You can also use petroleum jelly or an antibiotic ointment. Puncture wounds, so usually a small area that goes deep. You need to assess it for underlying damage, examine for any foreign bodies with an x-ray. You don't need to close it, but you do need to watch it carefully for infection. Crush injuries are the worst. Those have a loss of significant tissue. They need debridement and wound closure with a skin graft or flap. In terms of sutures, you can choose the size of the suture. The more zeros which are there, the smaller the suture. So 3 zeros or 4 zeros is relatively large. It's used on the torso. 5 zeros or 6 zeros is relatively small. It's used for the face or neck. 2 zeros to 4 zeros is quite large. It's used for closing deeper tissues. You tend to leave sutures in for over a week on the torso and extremities, and on the face and neck 4 days. In terms of where to place the suture, if you're closing a muscle, you would place it in the fascia, which is the greatest strength. And for the skin, you would put it in the dermis. So remember, there's the epidermis, the dermis, and the hypodermis, so it's the second layer. And in terms of materials, you can choose between absorbable and non-absorbable. Absorbable will be like catgut, chromic catgut, polycyclic acid, polyglycinate, and so on. Non-absorbable, nylon, polyester, silk, stainless steel, polypropylene. For skin, we tend to use the non-absorbable because it is less reactive, and that would include nylon, polyester, and polypropylene. For below the skin, then we can use absorbable, so catgut, chromic catgut, polyglycinate. And for fascia, we can use polyglycinate. In terms of advanced issues, chronic wounds could include pressure ulcers, venous stasis ulcers, arterial insufficiency ulcers, and diabetic neuropathic ulcers. In pressure ulcers, the patient is neurologically impaired or bedridden. We can prevent this by frequent turning and repositioning. Special attention needs to be placed to the heel. It's best if the heel is floating off the bed with a pillow under the calf. And if they do develop a pressure ulcer, you can use a special mattress to minimize the pressure, or a wound vac over the pressure ulcer. In venous stasis ulcers, that tends to happen when you have valvular incompetence in the veins. So blood pools causing areas of high blood pressure in the veins, which is transferred to the microcirculation of the skin. It causes leg discomfort, heaviness, and edema in that area. It tends to be in the superficial anterior-medial aspect of the leg, usually right above the ankle, so the inside of the leg above the ankle, and treatment is compression. So you'd use either paste bandages or weekly dry bandages. In arterial insufficiency ulcers, That's when we have atherosclerosis in the main arteries supplying the lower extremities. It's a very similar situation to the venous stasis ulcers, except they typically occur in the toes. It can also happen in the ankle and foot. Pedal pulses will be absent. You can double check this with a vascular ultrasound. Treatment is aggressive. We need to do bypass surgery to improve tissue perfusion, excise the wound, and do primary closure of the wound. In diabetic neuropathic ulcers, there is polyneuropathy of the neurons supplying the lower extremities. There also may be a motor neuropathy, which changes the way the muscles of the foot are able to grow and be used. Often in this situation, you may see Charcot's foot, which is a deformity of the way the foot is, the muscular and skeletal structure of the foot. Pressure is placed on areas where there wouldn't normally be pressure in certain bony areas. So we have small areas of high pressure. Typically, these are on the plantar surface of the metatarsal head, or the heel, or the dorsal area of the toe. So we need surgical debridement and primary closure of these. They can have special foot gear, but there is a risk of amputation. Thank you.